Alright, sorry about that. The video got cut off, so let me pick up where I left off. We were talking about 30 to 90 degrees of abduction, and as you can see here, once you're these 60 degrees of abduction, it requires the scapula to move at a little bit faster rate, or at least get some movement out of the scapula. If you don't, then the humeral head is just going to butt up against the AC joint here. You're not going to be able to abduct your shoulder. So like it says here, you get 1 degree for every 2 degrees of humeral elevation. So for every 2 degrees that the humerus moves, the scapula is going to move 1 degree. And you're going to need that. And you can see this with, maybe not so much with our athletic population, but with the elderly population when they get frozen shoulders and things like that, their scapula is not going to rotate as much. They're going to have weakness in some of the rotator cuff muscles and the supporting structures around there. So that scapula is not going to move as well, and that's going to limit their abduction. Finally, from 90 degrees to full abduction, you get 1 to 1 as far as ratio in degrees. So as the humerus moves 1 degree, the scapula is also going to move 1 degree. So this is where you see the scapula get a lot more movement. If you're evaluating someone from posteriorly, you're going to notice this, that as they're moving their arm up from 0 to about 60 degrees, there's not a whole lot of movement. And then from 60 all the way up to 120, you're going to see a lot of movement in the scapula. So the next thing, we'll go through some pathologies. We have a clavicle fracture and repair. As far as the clavicle goes, um, there's different severities as far as the fracture. So you can do a hairline fracture, you can do a complete fracture such as this, where it's displaced upwardly. And obviously, once you get to this point where there's two separated pieces, then you're putting all the structures that we talked about before, the brachial plexus, the subclavian artery, all those things are going to be at risk of being severed or damaged. So that's why something like this is going to be, um, you're going to need to be prepared for that. It's either going to be a 911 call, depending on if the athlete's conscious or not. Sometimes athletes can go into shock. But if they're not, then this is something that you can splint, make sure that the shoulder is not moving, and still call 911. Maybe you need a medical transport. If not, it's something that you can transport on your own, or have a parent transport the athlete immediately to the hospital. Like it says here, with clavicle fractures, there will be a gross deformity as seen on the bottom right. So right here is where you can see that. And this right here, you want to make sure you verify with the athlete, because maybe they've had a previous clavicle fracture, and this is just the way their clavicle looks like now. So you have to compare this bilaterally, make sure you get a good history on the athlete. Um, and if they already had this deformity, then right there you can kind of rule out that it's already fractured. But if they're still having other symptoms like extreme pain, like sharp pain, any numbness or tingling, as you palpate the bone and you feel some movement compared to the other side, then yeah, you may still have a fracture there. And like it says here, it says potential for trauma to the vascular and neurological structures, like I mentioned before. When we talk about AC sprains, we have to make sure that the reason I wanted to talk about this is because we have to be able to differentiate between an AC sprain and a dislocation. And the reason for that is because most people are going to use layman's terms. So if an athlete says, "I separated my shoulder," like if let's say you're going through your PPEs, you're doing a physical on someone and you're asking about their medical history, and they tell you, "Oh yeah, I've separated my shoulder." Um, that's where you need to verify what they're actually talking about, because a separated shoulder refers to an AC sprain. So this is an injury to the AC joint, and the ligaments surrounding it. And the problem with this is that an AC joint sprain or a separated shoulder can have the same mechanism as a dislocated shoulder, but I'll show you the difference. So, and then also separation, they probably mean it was a severe enough AC sprain to where they had a deformity like this, where they enough of the supporting ligaments were either sprained or completely torn to where the clavicle moved upwardly. So they're going to have a deformity where their clavicle is just kind of sticking up at the AC joint. Okay, this is not going to, as long as you can make sure what you're looking at, this is not going to look exactly like a clavicle fracture, because a fracture typically occurs in the middle here. The AC joint sprain, is going to be at the AC joint, at the tip of the shoulder. So, again, this would be a separated shoulder. Um, then I mentioned the sternoclavicular joint sprain, how it's going to be more of a risk if they dislocate it posteriorly. So here, this is just a slide to show you what we have in the subacromial space. So if you're not sure what you're looking at here, here's the clavicle. This is the posterior portion of the scapula, and here's the humerus. Here's your supraspinatus tendon, muscle tendon, and here you have the biceps tendon, and here's the subacromial bursa, and then you also have the brachial plexus that passes through here. And this is just a good slide to show you how crowded it gets in that space. So any injury to there is going to cause a lot of problems. So now we talk about dislocation. So dislocation is when we're actually talking about the humeral head coming out of the glenohumeral fossa. So I'm sorry, the glenoid fossa. So this is different than the AC joint. And here's the other issue. You can have both. Maybe you landed on your shoulder and you slightly sprained the AC joint, but right now you're dealing with the anterior dislocation, the glenohumeral dislocation as well. And these are all things that you know you're gonna test them, you're gonna evaluate them, and obviously you're gonna notice something's wrong with them, so you're gonna refer them to the doctor, and they're gonna be able to take X-rays and do some more special tests. But the issue here is, okay, once we get them back and they're doing rehab, you're gonna have to take all that into account. That, okay, maybe it was a subluxation, maybe the humeral head just slightly popped out, went back in, but they also are dealing with an AC joint sprain. So you're gonna have to make sure that you're rehabbing your athlete correctly, making sure you're not just strengthening the rotator cuff muscles and the supporting structures, but that you also take care in how hard you're going to push them, because as far as the AC joint sprain goes, you're going to need to keep that without movement for a good amount of time, depending on the severity. If it's a grade 4 or 5, you want them not really moving their shoulder for a few weeks, so that the AC joint ligaments can heal correctly. That you're not moving them around too much, and then that's gonna just make them build more scar tissue. So those are the type of things that you have to consider as you're evaluating something. So when we talk about a dislocation, you're gonna see a major deformity um, close to their armpit. If it's an anterior dislocation, the humeral head is gonna translate in front of the glenoid fossa, in front of the scapula. So instead of you seeing a normal pattern where the shoulder's kind of rounded here, you may see this sulcus sign. So this sign of, okay, there's a gap there, there's a space there. And if you palpate in this area, that's maybe where you'll find the humeral head. And I've palpated, I've reduced several shoulder dislocation, so I kind of know what that feels like. And This is not uncommon. You'll be able to see this right away. Along with the shoulder dislocation, most of the time, almost 90% of the time, they're also going to sustain a labral tear because as the humeral head slips out of the glenoid fossa, it takes a lot of force to do that. So it's going to um, bang up against the glenoid fossa and the labrum, or just grind up against it, causing a lesion there. So if you see here on this arthroscope, you can see where they're just kind of peeling off the labrum off the glenoid fossa there. A slap tear is a type of labral tear, but in there it specifically refers to a tear to the superior portion of the labrum, where it's the laceration is from anterior to posterior. So it's a very long lesion on the top portion of the labrum, and it just um, causes a ton of instability in the shoulder. This is something that requires immediate surgery. Like, this is not something that you can postpone to the end of the season. Rotator cuff tear. This is You're going to see this mostly with throwing athletes, or someone that was performing a pretty fast or powerful movement with their shoulder. But you typically hear about this with baseball players or softball players. Anyone who has any type of throwing motion, they typically sustain this type of injury. And the specific rotator cuff muscle is a supraspinatus. That's the one that typically gets torn. Outside of that, I mean, you can also tear some of the other three rotator cuff muscles, but that's one that you typically hear of getting torn and then needs to be surgically repaired. So as you can see here, this is the tendon that's rolled up over here. It's supposed to be nice and smooth, attaching all the way over here, but here you can see that it's rolled up all the way over here. And that kind of brings us to throwing mechanics. Make sure that you just review this. The different phases of throwing: wind up, cocking, acceleration, deceleration, and follow through. Um, this is a nice little figure of those different motions. So this is something that, if you're dealing with overhead athletes, you're gonna be able to break this down. And as they're returning, so let's say you're dealing with someone that had a slap tear and that went through um, a labrum repair. It's going to be a tough process to go through all these different phases again and to do it succinctly and in rhythm. So when you start evaluating them and giving them feedback, so let's say you're telling them, okay, you've increased in range of motion, your strength is a lot better, your balance on your arm is a lot better. When you get to this phase, you're going to need to recognize, okay, is there something wrong with the wind-up phase, with the cocking phase, acceleration phase? You're going to need to give them that type of feedback so that you know what to work on and what they need to work on. So when it comes down to creating the rehab protocol, this is kind of what's going to guide you if you're dealing with a throwing athlete. You're going to want to make sure that they can go through each of these phases, that they're not uh, creating any shortcuts and not creating any bad habits, just to try to kind of get back to playing as soon as possible. All right, so that's pretty much all I wanted to go over with you guys. Again, if you guys have any questions, if you have any concerns, please make sure to email me. I'll be in my office this week. You can also call me, shoot me an email, just start a discussion board if you have any specific questions regarding the assignments, or anything else like that. So good luck on everything this week. I wish you guys the best. Please make sure to complete all of these assignments with the due dates on the due dates that are given. The article review, again, like I said, is due this Sunday. Next week, your critical assignment is due. Oh, here's one thing I did want to tell you guys. So if you are not sure that you have the proper article, to do your critical assignment, send it over to me. Email it to me, and I'll quickly read over it and let you know if it's appropriate to do for this assignment. Because I don't want you to hand in your assignment, having done all this work, and then I have to tell you it's not really an appropriate article that you just reviewed. I have that video posted on week 7 about the instructions on how to do the critical assignment, so please review that if you need to. But basically, I break down the two options that you guys have. If you're still not clear about that and you have something that you like, you have an article that you like, just send it over to me and just ask me if that's okay to do. All right, so thank you guys, and I will talk to you guys next week.